So thank you so much to Sages for the privilege of presenting. Today I'll be presenting on post-bariatric surgery lab tests. Are they excessive and redundant? None of the authors have any disclosures to make. So we know that we have over 200,000 bariatric surgeries performed each year in the US alone. The American Society for Metabolic and Bariatric Surgery guidelines call for fairly frequent postoperative blood lab testing at 3 months, 6 months, 9 months, and then twice in the second year, and then yearly thereafter. We test a host of labs, including iron studies, vitamin B12, vitamin D, folate, thiamine, vitamin A, zinc, copper, etc. And we have found that, at least in our patient population, many of these patients have fairly low incidence of vitamin deficiency. Sorry, just going forward. In addition to that, patients often complain about frequent and extensive lab draws. Many of these patients have 8 or 9 tubes drawn. They also have these labs drawn prior to coming in for follow-up. So they have to not only come to the follow-up visit, but they also come in prior to that to get their labs. And with the frequent normal labs that are seen and the high cost of up to $40 to $200 per micronutrient labs, we wanted to look at the incidence of deficiencies among our patients. So given the volume and the frequency of these labs, we can conclude that there's a lot of costs that go into this. So we wanted to really just look at our results. So our primary aim with this study was to establish the prevalence of micronutrient abnormalities in our bariatric surgery population. And then our secondary aim was really to identify some patient characteristics that can predict lab abnormalities in the future. So what we did was we did a retrospective data analysis of all our patients between the years of 2016 to 2018. This had a total of 847 patients. The net total after exclusions was 557. And we looked at all the labs I mentioned earlier. I'll just mention here again CBC, BMP, all the vitamins, zinc, copper, iron studies. And then we categorized these labs into 6 groups. So looking at the 3-month, 6-month, 9, 12, 18, and 24 months. And we applied binary variables to these and then calculated descriptive statistics for each. We also did a logistic regression to look at a model for prediction. Of the 847 patients, the final N was 557. Patients prior to the EMR implementation were not captured in this group, as well as patients with outside labs that came in and were not populated into our EMR. So from this group, a total of 49% were Roux-en-Y procedures and 40.9% were sleeve gastrectomies. We had a comparable male to female ratio between groups. And similar to other institutions, we had a higher ratio of female to male overall, 4:1. As you can see by the graph here, most of our patients had a BMI greater than 40. And outside of obstructive sleep apnea, which was more common in the Roux-en-Y group, there were not many differences between the two groups, Roux-en-Y and sleeve, for hyperlipidemia or diabetes or age or any of the other factors. Now, these are the results here that we have, and I know it's a busy slide, but I want to draw your attention to a couple things. First, if you look at this row here for folate and vitamin B12, you'll notice that for many of these time periods, the incidence of any deficiency is actually 0. Now, if you look at the incidence of vitamin D, then you can see a rate as high as 45% deficiency at the 9 months, with some variability in between. So really the deficiencies varied, but if we take an even closer look, you'll see that, for example, for vitamin B12, The average total percent deficiency over that 2-year period for all patients was only 1%. Copper was 1.3%, vitamin A 2.9, folate 3.9, and zinc only 7.8%. So we did not do a comprehensive analysis of all the costs because given our payer system, it's very difficult to establish any of these numbers. But if you look at even just one of the cheapest tests, which is really the prothrombin, is $36. Or even a zinc level can be $58. If you sum all these values and all these costs for a complete panel of tests for these patients can be up to $1,600. So in just calculating this number for all the patients that are included in our study, the 500 or so, if you just take one of these time periods, it amounts to up to $800,000 or more over the 2-year period. If you then extrapolate that to the 228,000 bariatric procedures done in the US alone, this can mean millions of dollars in savings if we can just more accurately assign or do lab testing in these patients. Now, we did a logistic regression analysis to try to predict some factors that would lead to a higher incidence of deficiencies. And what we found was that preoperative nutritional deficiencies was actually the biggest predictor. So it had a odds ratio of 2. Previous surgeries had an odds ratio of 1.4. Renal disease had an odds ratio of 1.6. Age was also a factor. And then interestingly, hypertension, hyperlipidemia seem to be slightly protective of deficiency in the future. Gender, race, ethnicity, BMI, diabetes were non-predictive in future deficiencies postoperatively. And interestingly as well, the type of procedure, whether it was a Roux-en-Y or sleeve gastrectomy, was not predictive of future deficiencies. So really the limitations in our study, again, it's a retrospective study. We did have a lower number of patients, given that a lot of these patients were not in the EMR, and so it was very difficult to obtain all the lab results, especially for patients that came with outside institution labs. And then again, it's a single center study, but I think we can conclude that at least for an institution, these tests can be very costly, and they were seldom abnormal, especially for vitamin B12, vitamin A, copper, and folate. Over time, this can add to a very significant expense. We also found that preoperative deficiency in any micronutrient is predictive of future deficiencies. Additionally, some comorbidities, like I mentioned earlier, especially renal disease, is highly predictive of future deficiencies. And we obviously need to do further investigation using larger data sets to define the prevalence and refine the model to better predict at-risk patients and better allocate our resources. So thank you again, and I'll take any questions.